I can't hear Dr. Bowie at all.
Yes, that's why I want him to. I can't even hear him at all. And we are also on YouTube Live. So let me share the link with you. That's me. Hello, Madu. Should I send? I'm sending you the link now, the YouTube link, or should I just send to everybody?
Okay, Dr. Okawoye said you should link him on his other. He has another device. The name of the device. What's the name?
Device.
Yeah, Dr. Okawoye said you have another name.
So
he said he has another device.
Yes. What's the name? So that I just send it to him right now.
Yeah, I've sent that as a chat.
All right, ma'am.
Okay, Adefolarin Okawoye, please check and allow him in. Adefolarin Okawoye.
Okay, I've seen Adefolarin
Okawoye, please allow him to enter.
I've allowed him. Thank you already.
Okay, great.
Yeah, Amit, can you hear me?
Yes, we can hear you now. Thank you. Dr. Babajide?
Hello?
I'm here now.
Okay. Dr. Okawoye.
Joseph, is it a webinar? Joe, is it a webinar?
Hello,
or
can you hear me?
We can hear you.
Hello? Hello? Hello, can you hear me?
Loud and clear.
Yeah,
Yes,
I'm here.
loud and clear.
Okay, good. Okay, sure. Yeah, I'm fine. I'm trying to share my screen in a jiffy.
Dr. Jumake.
Yeah.
Joe, are we doing a Zoom meeting? It doesn't look like a webinar.
No. We can also use. I'm sending you the link of the YouTube. You can also watch it on YouTube. It's live on YouTube too.
Okay, fantastic.
Yes, I'm sending that.
But the live streaming begins when Dr. Okawoye starts speaking, isn't it?
I think it has started.
It has started. Okay, brilliant.
It has started.
Anyway. Okay, Joe.
Yes.
Can you share the link on the chat group for the managers? Apart from, so that they also know that is live on YouTube. Thank you.
Okay, I'll do that now.
I haven't seen it. Dr. Jumake, have you seen it? I haven't seen the.
Yeah, we're just waiting for Dr. Okawoye to put up his slides, then we can start. I haven't seen the link also, so.
Okay. Okay.
I've sent it to your mail.
Oh, my mail.
Yes.
Okay,
Let me send it by WhatsApp now.
Okay. We'll expect the WhatsApp.
I think that's quicker.
Great. I can see your screen, sir.
Okay, man, good.
Okay, so waiting for your WhatsApp.
Okay, I haven't seen the screen. So that means I'm lagging, Dr. Jumake.
I like it.
Okay, seen it.
Okay.
Mr. Joseph, have you shared the link via WhatsApp?
Yes, I have.
Okay, to the general managers group, right?
Yes.
Okay, all right. Dr.
I will.
Babajide, I think we're
can't
good to
see
go.
it. Yes, but apparently we are the only one here.
No, we want to tell Joseph now to let everybody in. So are we good to
Okay.
go?
Yes, please.
I'm
Dr.
good from here.
Obaoye, are we
I'm
good
good.
to go?
Yes, I'm good from here. I'm good from here. Thank you.
All right. Mr. Joseph, please let everybody else in. Mr. Joseph,
Yes, ma'am.
please let everybody else in.
Done.
Dr. Babajide. Okay, that's Sister Fat.
Good afternoon, everyone. I will do a quick run through the agenda. That's the order in which we'll go. So we'll start at 2:05 with the speaker speaking. But the speaker will start in exactly 4 minutes. Now we're going to make interactive. He will be speaking for about 1 hour or even less than 1 hour. He's decided to split his presentation. But the good thing is I'm not the speaker. The speaker has got it'll be starting in 3 minutes. And I'll start again. The presentation is in 3 parts. So we will speak for about 20 minutes. We'll take 2 or 3 questions. Then it will another 20 minutes. We'll take another 2 or 3 questions. And then at the end of the whole session, we'll be able to take more questions. So please, if you have any questions along there, you can go to chat box, type in your chat, put your question in the chat, or you raise your hand and go on. Dr. Power, are you ready?
Yes, I am.
Good. You have the floor.
Okay, thank you very much. Top of the afternoon to everybody. It's a pleasure, honor, and privilege to be here. It's not every time you get the opportunity to talk to probably the foremost private hospital in Nigeria, known to have a lot of significant milestones and pioneered the development of medical care in this country, offering standards similar and even greater than what people get abroad. It's really a privilege to quickly, over the next 1 hour, have a discussion on COVID-19 exposure in the workplace as concerns us in the hospital and what we need to do. My name is Folari Opawe. I do infectious diseases at the Lagos University Teaching Hospital, and I also lead the IPC team for the state COVID-19 response. So, like Dr. Babajide said, it's going to be interactive. I will speak for a while, and then we can always do our questions, and we'll start at regular breaks to answer questions. Basically, today is not going to be another start bombing session, or I'm not here to inundate you with data, but just more or less to tell stories. Incidentally, I've been privileged to be in the midst of this COVID pandemic right from the start in this country. And we have a lot of stories that have not been told and may never be told. So I'm just going to share those stories, and I hope in telling those stories, we're able to pass 1 or 2 messages across. So basically,
you hungry? You have their food.
So I'm going to start now, and we know that all this started sometimes in December. It was said that the very first case was December 8th in Hubei province in Wuhan, in China. And then the WHO, of course, was alerted about cluster of pneumonia cases of unknown etiology. We all know sepsis quericose, anemia quericose. They had fever, cough, quericose. They didn't find what was wrong. And then by January 9th, the new virus was discovered. And before you know it, it had gone global. And, we had about 3 deaths were already reported as far back as January 21. There were 15 cases were recorded. By February 15, we had the first case in Africa. And of course, the disease is called COVID-19 and the virus SARS-CoV-2. So there's a market in Wuhan where everything started from. This was the first market. And it was thought that the virus actually mutated from probably the bat and the pangolin. And by January 30, WHO already saw, look, this thing is not going anywhere good. They declared as a disease of public health emergency of international concern. And the first case in Nigeria was identified in February 27. We had by March 11, the WHO declared it as a global pandemic. And worldwide, as of today, we have more than 55 million cases. And there are 65,982 cases in Nigeria with 1,165 deaths. Now, as I always tell people, these values in Nigeria may not be very, very correct. We have whole entire states like Kogi State denying and insisting that they don't have a single COVID case there. So it becomes a bit difficult to really say whether we are getting it. We know we are not testing enough in Nigeria. We know there are a lot of deaths that are unrecorded, like deaths especially in the northern part of the country. So the numbers may not really be the true reflection of the number of cases we have. But at the same time, we can also agree that the disease has not been as severe as it has been in the developed world for reasons best unknown up till now. This is Dr. Li Wenliang. He was one of the first doctors to try to warn the public about coronavirus. He was arrested for this. He was charged for disturbing the public peace. That picture is, it was on a breathing mask there, that's a CPAP mask. And unfortunately, he actually died about 4 days after that picture was taken down in February. And it was just 54 years old, great man. I like to reference him anytime we're doing this because he was one of those who really saw the danger. This is Dr. Amara Allison, and she was the one who identified the first case in Nigeria. Very brilliant young lady who she worked with Lafarge, and with this wonderful intuition of women, when the man came in the first case, he came with a fever, no other symptoms. But just because they had trainings, like this kind of trainings that we're doing now, they had trainings in the company. And she just felt that, look, you coming in from Italy, there's an outbreak in Italy, let's check. And that was not a popular decision. I mean, she was vilified for that and all that, especially by the patient. But then eventually the guy came out positive, and we started the rigmarole since then. So this is the index case in Nigeria when he was getting discharged. And it was a very, very interesting case because at the point we were making a diagnosis, there was a lot of pushback from all over, from the Italians, from the patient himself. Oh, you guys don't know what you're doing. We don't even right. And of course, I mean, it was difficult, and we just had to prove to him. Incidentally, his own family, he had an outbreak in his own family in Italy then. He lost some of them, and so he knew that, okay, like, wow, this thing is real. And this was at the point he was discharged. It was a very emotional night for him because he was really thankful. He thought at some point he would die, but due to gallant efforts of the managing team, hopefully, thankfully, he survived the experience. And so, I mean, I like this picture because as at this time, this was news. 5 new cases of coronavirus disease in Nigeria. Everyone, oh wow, this was 18th March. I mean, now if we test 100 people, we're sure we'll get 5 cases. If we get less than 5 cases, we get worried. And at some point, this was news. I mean, this news was, it was a minister himself that was given daily briefings every day on the number of cases we had and all that. But now we've gotten way, way beyond that. But this just reminds me of where we're coming from. And this is a trend map showing the trend of cases in Lagos. We can see from, we started monitoring this from March 18. The first case in Lagos was on March 11. That case, the first case in Nigeria, was stated as an Ogun State case because the guy didn't really stay in Lagos, he just passed through. And, you could see the peaks we had in May, June. I mean, I recall the day we had about 600 cases. That day I just gave up, like, okay, we are in for it. And then we had this lull, very strong lull in August. Things were a bit calmer, and then only for things to start shooting up again. So there's been a lot of speculation as to are we in the so-called second wave of COVID? Because now all of us, if you are active in the hospital setting, now we're seeing more people coming with fever, desaturation, coming with difficulty in breathing, and so the reality is that we may actually be in this predicted second wave, which a lot of countries are already seeing. And let's talk about healthcare worker infections with COVID. And what we know is that the first study that was done in China in January, about 1,760 healthcare workers were already infected. In April, we had over 100 doctors that died. And in Spain, 10,400 healthcare workers have been infected. We look at the CDC data between February 12 and April 9. There were 9,282 healthcare worker infections with 27 deaths. Now, fast forward the data, okay? By the time you look at the data again, between February 12 and July 16, we have 100,570 healthcare worker infections. That is a 10 times multiple the number they had in the previous update, and it just shows you what is going on with this, with 641 deaths. That is a lot. And when you look at all the experience, all the years of work that is lost in this COVID, we have never dealt with something this devastating in the medical world. I mean, we've been treating infectious disease for decades. All of us have probably seen HIV patients, hepatitis patients, TB patients, and we're all fine. We don't all have HIV, we don't all have TB, we don't have hepatitis. I mean, these things could occur, but they're very rare. But the reality is that most people dealing with COVID have gotten it in one way or the other. Most people, and when you see this data coming from developed countries, from countries that have far better systems that we do, countries we are trying to be like, it gets you a bit worried as to what exactly is going on. And the challenge here is that when you look at the breakdown of the data, the sub-analysis, you can see that most of the infections was actually among the healthcare support workers, who are the health assistants, the nursing aides, the care aides. They were the ones that bore the brunt, followed closely by the nurses, because we know that nurses actually spend the highest amount of time with the patient and the closest contact with the patient, and so they actually suffer more than most people. So the people that spend the prolonged contact with the patient are the people most at risk. Unfortunately for the people in the cleaners, the nursing assistants, the ward mates, some of those people are not the best people at following some of these instructions and some of these guidelines. And that's the challenge, where one of these people gets infected and then infect the rest of the health team. Even doctors are not so much. If you look at the data here, 1,895 healthcare support workers, nurses 1,742, doctors just 190 were infected by the virus. Now, when we look at the Pan American Health Organization, they estimate that 570,000 healthcare workers have been infected in the Americas, that's in South America, who have really suffered from it, and over 2,500 have died. The Kaiser Health Network and Guardian estimates that over 1,390 workers have died in the US, and WHO says about 41,000 healthcare workers have been infected across Africa. When you look at the data, some analysis of the data from the US, again, nurses are really, really hit. Nurses, 90 nurses, okay? 90 of them are nurses, 34 physicians. Again, look at the support staff, 51, okay? Even admin is involved, 16. And so everybody, this is not just because there's that tendency for that HR person, for the person admin, to feel like, look, this is a doctor's problem. Okay, I'm not seeing the patient, so how is it my concern? Why do I need to learn all those things? But reality is that all those people, that by virtue of the fact that they are working in the hospital setting, they are all at risk. Whether working as janitors or as cleaners or as clerks or as secretaries or admin, everybody is at risk because they are working in the hospital. And this is what we have seen all over the world. Let's come to Lagos, Nigeria, and look at some of the data we tried to gather. In June, we had more than 500 healthcare workers have been infected. About more than 70% of them were asymptomatic at that time. The reality is that most of them were from private hospitals. And as of that, then we had 15 deaths, doctors, nurses, drivers. It's cut across all the sectors. The deaths that we had from COVID. Again, when we did a sub-analysis of the data, well, in Nigeria, we had quite a high number of doctors, maybe because many of them were the ones getting tested, but again, closely followed by nurses, but every single cadre was affected. And for the doctors, regardless of the number of years they had, regardless of their specialization, all cadres, all ages were affected. And that was something that was significant. So it wasn't as if, it was because they were young doctors. I recall a time I was working in the isolation center and I had an entire bay all filled with professors. These were very, very experienced people. The combined medical age in that bay there, in that room was more than 100 years that these guys have spent in the medical field, and yet they all got infected with COVID, and many of them not even directly from taking care of the patient. So these are things that it's very, very crucial for us to understand. And these are some of the pictures. These are collages formed from the pictures of healthcare workers who have lost their lives to this deadly virus. And I just always pray that none of our pictures is in any of these collage systems. Okay, these are collages. They are all made up of people who have died. So the question is, why is this hitting us so bad? I mean, unlike all the infectious diseases that we have handled. Look, Ebola, Lassa, we treated it. We handled Ebola in Nigeria. Not a single healthcare worker was infected. We deal with Lassa every year. We've had some deaths, right? But not to this level. And then, so the reality is that most people have unsuspecting exposure to COVID patients. And most of these exposures and most of the deaths that have occurred in Nigeria are actually not from people working in the isolation center. They are from people that are working uh, in the normal hospital setting, and then they somehow come in contact with these patients without knowing, and then by the time they know, it's already late. So that's the challenge. Of course, healthcare workers have multiple sources of exposure. We discovered healthcare workers then. We had doctors, nurses who had COVID and they were on leave, so they didn't get it from work, because that's the assumption again. When you see a doctor with COVID or a nurse with COVID, you assume that the person got it from the hospital. It's not true in all cases. Okay. Of course, lack of PPE was a big issue, especially in the earlier part of the year when PPE was crazily expensive. It's better now. Improper use of PPE is a much bigger issue, because it's not just about having PPE, but people are not using PPE well, and then it becomes a serious problem. And then fatigue, it's also an issue. You know, when people are tired, they tend to make poor judgment calls, and it could be dangerous. You know, so I just like to go through some of the notable patients we've had. This is one of the highest ranking cases we had in Nigeria. Chief of Staff Abba Kyari, we lost him to COVID. Again, Donald Trump was also infected, and I mean, I'm not a politician, but I believe that COVID was probably one of the strongest reasons why he probably didn't get reelected. And we had Boris Johnson too, who was very, very sick. He was actually in the ICU, and somehow, in fact, it was so sick that he had already prepared his obituary, kind of. But thankfully, he reversed course and he survived. We also have Jair Bolsonaro, the president of Brazil, also another patient. And I mean, when I saw these pictures, I wasn't really surprised that he had COVID. Not saying that it was because of this he had COVID, but you can see that this is clearly a man who really doesn't know how to use his mask. The reason why I bring these things up is because some of these individuals are the most secured people in the world. They are the most protected in every way, physically, spiritually, and otherwise. And if the COVID virus got into the White House, got into Downing Street, it got into House of Rock, and virtually every single presidential palace in the world, then I don't care the kind of protections you have, you would have cases. And that is the truth. And that is what we have discovered. Because we don't have systems as good as some of these systems that they had. And yet the virus got there. So it's just one thing to learn about the virus. It's a bit inevitable. And we just have to learn how to deal with it. I just want to quickly also go through some of the doctors we've lost in this country. Dr. Emeka Chubo was the second doctor that died in Nigeria. The first doctor that died, that was Dr. Yusuf he came in from Katsina. Incidentally, he came for a doctor's conference in Lagos, got infected in Lagos, then went back and died in Katsina. And Dr. Chubo too, he lost his life from he inadvertently caught COVID from a patient unsuspectingly. He didn't know. The patient just traveled in from Dubai, and he went to see the patient, and fortunately he started getting sick. And then by the time we started doing contact tracing, discovered that even the patient died, and then unfortunately he also lost his life. Dr. Olusegun George, also private hospital in Bariga. He also had COVID. A lot of his family got infected, and I mean, these stories are in the public domain. That's why we could share them, right? And also to give a nod to them. They are all resting in peace now, and just to appreciate the efforts of the heroes and to bring this thing real to us. Probably the most painful, I don't know, since I've been dealing with COVID is actually the death of this young man. Dr. Valentine Egbado, who actually passed through my institution as a student and as a house officer. You know, it was the life of the party, very, very vibrant young man. And was really worried when this happened because I was really shocked. He was young, very fit, was in the football team everywhere, and he died. You know, and that's a problem with COVID. You know, you can't really predict who will survive and who will die. We've lost 96-year-olds, 90-year-olds. They went home, okay, and then this young man without any apparent comorbidity, and may his soul rest in peace, was buried last week amidst a lot of tears. And you know, so there are different phases of the pandemic in COVID, and we have the phase zero there where you have this serious peak where we had a lot of cases, and Nigeria was at this point April, okay, April we had so many cases, April, May, okay, April, May, June. You know, we went into this full lockdown, and there were so many procedures, and that was when hand sanitizers were sold for ridiculous amounts. People were masks. I personally bought a box of masks at 15,000 naira, you know, just because of it was the prices went so high. But after some time, the virus calms down, and then you get into phase one, phase two, phase three. You know, we're there in August, you know, September. But the problem now is we're having a secondary wave. We are, because for those of us at the user end, at the hospitals, we're seeing them coming again. We're having an increasing number of admissions. And the challenge is that the phase four in some countries, in the UK and in France, for example, is even more than the zero. We hope we don't get there, but that's the reality. And we just have to see what's going on and then try and prepare and get our acts together so that we can learn from what's going on all over the world. Now, so the dilemma is that, if cases and deaths are rising, why is the government opening up everything and people no longer wearing masks, people are not taking precautions? That's really been something that is very, people are angry that why is the government quote unquote irresponsible and opening things up and despite the fact that we are having increasing number of cases. Well, the reality is we just have to move on. And that is what the whole world is realizing now. And, regardless, because the economy has tanked in many countries, there's a lot of unrest, people are hungry, they have to do bailouts. And for those of us, we were here during the lockdowns, we never worked because people couldn't stay at home. And so people have to move on. So there's something called pandemic fatigue, which I'm sure a lot of us are already experiencing, in which we're just tired. We're tired of wearing masks. We're tired of, having to stay away from people. We're tired of not hugging people. We're tired of washing our hands all the time. We're tired of quote unquote being paranoid. We're tired of being locked down. It's really been a challenging time for so many people. There's been a lot of mental health issues. And all over the world, people are just tired. And like say, look, I don't care if I die, I die. I just want to move on. Okay. And that's the thing. And that is why the level of restrictions that we saw at the level of compliance that we saw at the earlier part of the year is no longer what it is now. Okay. But you see, the problem is this: the death of one man is a tragedy, and a million deaths is a statistic in the world of Dugashvili Ivanovich Stalin, the former dictator of Russia. And when they say about 1.5 million people have died from COVID worldwide, if you don't know anybody, it doesn't touch you. And I recall when Dr. Valentine died, the next day, the whole of the hospital, everybody was maxed up. People were so scared because all of a sudden it was real. It was something up close and personal. And we don't have to wait for that. That's the truth. I know people are tired. We are all tired. These things are not easy. We are feeling suffocated and feeling breathless with the mask. And I know, but the reality is that we just have to keep doing as much as possible until the danger passes significantly. So at this point, I'll pause now. I don't know if we have any questions. Thank you very much.
Thank you very much, Dr. Powe. As it is, I do not have any hands raised up. But if anyone will ask the question, can you chat the or raise your hand before we continue. Any questions, please? Can we assume then there are no questions?
Dr. Babajide, I have a question.
Oh, thank you. Thank you, sir. Go ahead, please, Dr. Lumoli.
Dr. Okwawe, thank you for that impassioned presentation on COVID. And I feel much the same way as you on a lot of these conditions. My question, and I don't know if there's an answer to this, but when we look at healthcare workers, do we have enough statistics presently to tell whether the preponderance of those infected got infected in the hospital setting or outside? Because as we all know, this disease is now community-based. I don't know what the statistics are in Nigeria, but when you look at statistics from other countries, especially when there have been analyses of where there have been outbreaks in hospitals, and they've been able to do even the genomic fingerprint of the virus causing the infection, it's been quite clear that the exposure is multi-centric, and in fact, most of the exposure was from outside the hospital, not within the hospital setting. Do we have anything, any data on our experience in Nigeria?
Okay, thank you very much, Dr. Duale. So local data, not really. I think we have only one or two centers that can genotype in Nigeria. It's very difficult to do. If you don't genotype the virus, it's difficult. I mean, it's just going to be your word against my as to where the person got it from. So, but what we know, like you said, from data we got from the US, is that I mean, quite a lot of people, healthcare workers got it from the community. Some of them got it from the hospital. Some of them you can't just be sure. Because for us in Nigeria, we just make it anecdotal. If you haven't been to the hospital, like you say you're on leave and then you were tested and got COVID, then we say, okay, fine, you didn't get it from the hospital. You got it from somewhere else. But that's the challenge. And you know, the problem is that the hospitals, probably most hospitals, good hospitals, will follow the rules better than most other establishments, you know. And so the hospital might actually be a safer place than some other places. For example, you have a doctor or a nurse who went to the club and then came to the hospital and then had COVID, and then, oh yeah, I got COVID from the hospital. It may not be true. I mean, you're far more likely to get it from the club where there was no social distancing, there was nobody wearing masks, than before he's getting in the hospital. So we really don't have the resources to conduct that kind of research in Nigeria. It's just anecdotal. It's going to full of holes, but yeah, there are multiple sources of exposure for the doctor, and the challenge is the multiple sources of exposure makes it easier for them to get, because when you're at work, you're at risk. You go home again, you're at risk. So the risk is sort of like double and triple for many people. Thank you very much.
Just to follow up to that, the reason why I asked that question is because I want our audience to appreciate the fact that you know, you come into the hospital, you've got your PPE on, you wear your mask, you're doing all the things you need to do, your hygiene, hand washing, and all that. But when you go out there, it's probably even more important to continue to safeguard yourself by sticking to those measures, especially measures to do with social distancing. And your mask the utility of the mask is very limited if you're not doing social distancing. You're not taking some of those other measures. The mask is really, in terms of hazard control, is personal protective equipment is one of the lowest methods of reducing exposure to hazard. I just want people to realize that and to emphasize that for our audience. Thank you.
Thank you very much, sir.
Thank you so much, Dr. Oluwole. I have a question here from the group, and please, we will have to take his question, Dr. Kwawe. Mr. I can ask this question. Are you muted?
Hello, yes, I'm here. Hello,
Yeah, go ahead, everyone. Please.
Yeah. Okay, I want to make a kind of a question, and I think because I heard that the doctor that just presented is also handling for Lagos State. As I'm now in Lagos, from what you just said now, it is glaring that we are all, apart from healthcare workers, even those that are not healthcare workers or our family members are exposed to this COVID-19. And as at now in Lagos, the government testing center has conditions on ground before you can present yourself for testing. You can't just walk in to say you want to test. According to what's on ground, you must show the symptoms or there are some characteristics before you can present. And for the private sectors, for the private testing labs, government also make it a little bit expensive for people to come in to say, I want to test. And apart from that, the government itself has a certain amount that is being levied on everyone that comes to test in a private lab. In this situation that the thing is biting harder, it's affecting the economy, it's affecting the health of the nation. Is it necessary for Lagos State to be charging as much as 10,000 on everyone that comes to test in a private lab, that they have to pay 50,000? But the 50,000 they are paying, the state is charging on it with the excuse that, oh, administrative and all sorts. Can't Lagos foot that so that people will be encouraged to come out to test, and we will be able to know where the issues are, not until we get to a point that when we're not doing what do you call it, tracing. We now realize that this thing has bites so hard. I'll give an example. Recently, one of the labs came up. Somebody had a marriage ceremony, and after the ceremony, they now realized that maybe the bride or the groom or one of them had COVID. So they had to do tracing, and after the lab did tracing, almost 8 out of 10 of those that were in that party, almost 8 out of 10 that were able to trace to test, they have COVID. Can we still continue with this course of testing as things are now? That's my question, sir.
Okay, thank you very much, sir. Yeah, so this is the challenge. Probably open it up with the caveat. I don't speak for Lagos State government. I'm actually volunteer with the government myself, just there a bit more for my expertise and experience. So basically, this pandemic is very expensive, extremely expensive. And I mean, I've been in meetings where billions were discussed, billions of naira, and billions of naira have been spent so far. And if you recall, when this pandemic started, the government was responsible for every single thing that was going on as per testing, and that is extending even up till now. So the issue why the government pulled out, and not really pulled out, but is because when the private labs came in to sort of help the government, I mean, and then the government said, okay, fine. The government is responsible for surveillance-based testing. So if you are a contact of a case or you're having symptoms, the government will test you free of charge. But if you're coming that, oh, you want to travel, then it's not viable. So that's the thing. We still tested, I mean, we have had outbreaks in places where we tested 400-500 people, and all these tests were done FOC, not a single cover was collected from anywhere. But when it's not surveillance-based, that is where the government charges. And I hope this information is out there. And that's what I'm telling you now. If you have anybody who's a contact of a case or who is sick and wants to check, free. In any of the government, you can walk into any testing site. But the challenge is people coming in and, oh, they are traveling, or they want to do COVID test, or, oh, I want to get a new maid, I want to do a COVID test. No, we don't do that. That is not done. Because again, if the government does everything, then these private labs that have invested a lot of money, they would not be able to, they would not be encouraged to continue. So that's where we are, sir. Surveillance testing is still free. So for example, this wedding I talked about, I also know about the case. If they had walked into the government testing sites that, okay, there was a contact or there was a case in the wedding, everybody will have been tested, even if they are 1,000, without collecting 10 kobo. And the government still does hundreds of free tests every day. So I think it's just a thing of information as to how to get this test done if you're a case. But for people who are traveling or anything, no, the government wouldn't do the test for them. Thank you.
Yeah.
Dr.
Dr.
Ajay,
Powell, can you hear me?
okay.
Okay. Okay, we can hear
No,
you
I'm
now.
unmuted. Yes. Okay, Dr. Powell, you have the floor. You can continue.
Okay, thank you very much. I saw in the chat that somebody has a question. Maybe we ask at the next break. Blessing Ade, I think Ade. Oh, sorry, there's my hand now. Blessing Ade Shida also. Adetola has a question, but maybe probably we're able to ask later. Thank you very much. Thank you for those wonderful questions. So we move on now to really just quickly talk a bit about the virus, and this is important because we need to understand the virus so that we can understand how to deal with it. If we don't understand, and that's one thing we've seen with COVID, we've seen people waste hundreds of millions doing things that are totally unnecessary in their fear to stop the COVID virus. So, and it's of course it's a new virus. We just discovered it this year in January. Similar to other coronaviruses, but slightly different from SARS-CoV and MERS. It's from the general family of the coronaviruses, and it was first discovered in 1965. And the yellow, the spikes on the crown, was what gave it the name corona. So, question which is very important is to ask is how do people get infected? Because if we do not know how people get infected, then we're doing things that are not necessary. For example, you cannot try and use mosquito nets to prevent yourself from getting cholera, and you can't say you're boiling water to prevent yourself from getting mosquito. Or then you want to eat good food to prevent yourself from getting Lassa fever. So every infectious disease has their own pathway, and it's very, very important to understand how, because then what we try to do is to try to counter these things at their own different areas. So for COVID, what we know, and it's been a lot of controversy on this generally, is that it's majorly spread through respiratory droplets. So somebody, you're in close contact with somebody, the person coughs, talks, or sneezes, and then the other person can inhale, or it can land on the person's mucous membranes directly, and that person can have COVID. And that's the major way that it's transmitted, probably more than 90%. We also know that there could be indirect contact through the hands, meaning that if somebody coughs, sneezes, or talks on the surface, and then the hand touch it, and then goes to the face, then there's a risk. But that risk is low. That's what the studies seem to have concluded for now. And we also know that it could be airborne under special circumstances. The issue of airborne or not airborne created a lot of problems in the scientific community, with scientists writing to WHO as to the fact that the WHO is denying that it can be aerosolized. But what data has shown is that under circumstances of poor ventilation, then the virus could stay in the air a bit longer than you want. It can transfer, it can move farther than you want, and then it could cause an infection. But under those circumstances, it's not a major means of transmission. We know the virus can be found in blood. Okay, some studies have found it in blood, some haven't. We know it can be found in stool. We know it can be found in ocular secretions, and we know it can be found in semen. But while the viruses found all these specimens, they do not have significant contribution to transmission. One of the biggest issues we had with COVID then were the labs. When COVID came, the labs absolutely refused to test the samples. Just because of the fear that they could get it. But COVID is not HIV, it's not hepatitis. You can't get COVID from a needle stick. You can't get it from blood transfusion. It is a respiratory virus. So even though the virus is found in them, you can't get it from them. And then a question that people usually ask a lot when we're doing training is that can COVID be transmitted during sexual intercourse? Which is interesting, of course. Nobody has really been able to do those studies to show whether it's true or not. But yeah, it's very, very likely because there's a lot of close contact involved. And the chief of one of the chiefs in Canada actually wear a mask and kiss very sexual intercourse, but that could help. But it's very important for us to understand these various means of transmitting the virus so that we can be able to know how to protect ourselves. There's something we call the chain of infection or the chain of transmission in IPC. I wouldn't go through all the nitty-gritty of it, but every infectious disease has 6 links in the chain, from 1, the infectious agent, to 6, the susceptible host. And just like Dr. Oluwole said when he was during his comment, PPE, the way this chain works is that the closer you are to the end of the chain hence at the host, then the more likely that you're going to get infected. And so you want to really do things faster. And that's what Dr. Oluwole said. But by the time you are relying on your mask to protect you, the mask works at the portal of entry, and it's already getting late. It is already getting too late because no PPE is 100%. And that's the reality. And that's why when a lot of people overemphasis on PPE, and I mean, those are some of the things that we have been able to work against, even here in Nigeria, for example, because we don't have the resources to procure the amount of PPE needed. And many times we have to just be very creative. And we've done that with very successful results. Of course, droplets are transmitted. Everybody generates droplets. I've probably generated millions since I've started this discussion. And there's more, probably generated the highest amount when we're sneezing, when you cough, when you talk, when you sneeze, there's a lot that is generated, and these droplets are the ones that carry the virus. And these are studies that are done to show how these droplets travel and in a bit to try and understand how the virus is transmitted and the things that you can do to prevent it. The reality is that the science of many of them is quite, it's not very, very, very strong. And that's why there's been a lot of controversy in the scientific world, whether masks work or not, and the actual distance for physical distance is 3 meters, is it 6 meters, 10 meters. Many of these conclusions were not really based on strong studies like that. But we are working with what we have. And as we go, we are trying to gather more data. So now we get to what are the signs and symptoms of COVID. Now, this is very crucial for everybody to know why. Because when you have these signs and symptoms, ideally you should not come to work. And this is something that has been a serious problem all over the world and even in Nigeria. There was a particular case we went to investigate in that hospital. The person has been having all these signs. He was having them for 2 weeks. And he was coming to work every single day until the head of the team noticed that, hey, you're not feeling too well. What's the problem? And then he stated all his symptoms, classical COVID. And then, the hospital was appalled. So everybody has to understand these signs and symptoms so that then we can know that, okay, when you are having these symptoms or you have anybody around you having these symptoms, then it's best for you not to show up, or you should actually alert the authorities and get tested. Now, the challenge with COVID, which makes it very, very difficult to really control, is that you have significant number of asymptomatic infections. Okay, that means people that are positive with COVID and they don't know because they don't have any single sign. Or people who are positive with COVID, call them pre-symptomatic. Initially, they are positive, but then they will show signs later. But right now, they are not showing signs. Okay, they are fine. They are healthy. They are like normal people. And what we know is that these two groups of people can transmit the virus. But what we also know is that they are not very efficient in transmitting the virus. So we don't tend to lose too much sleep over them, but they are there. And so it's very, very significant that we know that. Okay. One of the common signs is fever. Almost 99% of cases sometimes have fever. The problem with the fever is that fever can be conquered in so many ways. You can take analgesics, take paracetamol, you can take a bath, and this is a challenge why many of the temperature screenings don't work. Okay, because the person may not be having that fever in your zoo at that time, and may have had it before, or was going to have it later. So that's the challenge. Okay, headache, anosmia dysgeusia. Those are very, very specific signs. Not many people have them, and a lot of times, every single case of anosmia and dysgeusia that we've had, they all turned out to be COVID without any without any one of them not being COVID. So because these are not very common things. So once you can smell, you can taste, we know that most of the time it's COVID. Sore throat is another issue. Diarrhea, cough, chest pain, difficulty in breathing. If you look at all these signs, they are non-specific. I mean, apart from anosmia dysgeusia, which is not caused by so many conditions before now, that we can say, okay, fine, this is most likely COVID. But fever, okay, anything could cause fever, right? Fever, anything could cause it. And the challenge we've had with many patients, they come in 3 weeks and they'll tell you, oh, they've been treating fever for the past 2 weeks. I'm like, wow, this is COVID and it was missed. And before they come, sometimes things are too late. I've walked patients into the ward and they've died the next day. They walked in. But the challenge is that they've been sick for a while and they didn't know, they didn't take any report. So what we tell people, any case of fever now, don't assume it's malaria. Go for a test. And like I've said, if you go to a government center, oh, look, I have fever, I'm not feeling well, they would test you. You know, the test will be done. Now, the good thing is that most people with COVID are going to be relatively mild infections, more than 81% in some studies. Okay, is the remaining percentage that will be issues, 15% of them. Out of that 15%, out of the remaining percentage, 10% of them will be very sick. About 5% of them will need ICU. Of course, we know anybody getting towards the ICU is just usually a bad case most of the time. They may not survive. But the challenge is we don't know who will fall into which category. And that is why we can't just, we need to be careful. All right, like I've told you, one of the doctor that died recently was just 33 years old, and we've successfully managed 96-year-olds with the same virus. Okay, so it's really difficult to say whether this or that. It's like Russian roulette. Now, the question is this, which is a very important question: can people get reinfected? Yeah, so now we know that some infections offer lifelong immunity, like chickenpox. You can't get chickenpox twice. If you have it the second time, it's herpes zoster. But we have seen cases of reinfection with COVID. They are rare, but they occur. And sometimes people die from the second infection. What we know with COVID is that you have some form of immunity from it for at least 3 to 6 months. That's what we understand for now. But what it means is that the fact that you had COVID before does not mean, it means you are protected more than the naive person, but does not mean that you cannot get it again, and it does not mean you should throw all caution to the wind. So that's very, very careful. We still have to be careful. Who is vulnerable to COVID? We know, like I said, everyone can get infected. We've had infection in people as young as 6 months. We've had in people as old as 95, 96. Okay, but the severe disease affects the elderly. Okay, and people with underlying diseases. Okay, like hypertension, diabetes, asthma, COPD. All these diseases are things that when COVID hits them, they could get worse. Interestingly, we've also seen people that have these conditions that they survive. So it's really, again, neither here nor there. Pregnancy too could be bad. We have successfully delivered a lot of pregnant women, and some of them have also died from COVID. So, but what we know is that most deaths occur in people that are old and those with underlying disease. The youngest death we had in Lagos was a 5-year-old child who had a leukemia, okay, and then he had COVID and he didn't survive. But that's just the deadly nature of COVID, where you can't really predict who will survive and who. And all over the world, we've had very young people, otherwise fit, no underlying comorbidities that died. And so that's why all of us have to be careful. Now, question is, how is COVID diagnosed? Of course, PCR is the gold standard. And, you know, of course, there's been a lot of controversy over these tests. They are extremely expensive. And it's just been challenging for the average individual to get a COVID test. Well, rapid diagnostic test kits can be used, but they are poor sensitivity and specificity. You know, they don't really work so well. And sometimes we use CT scans to help and aid us in our diagnosis. Now, it's very, very important to quickly say a bit about testing here, because when the question came up about testing, I knew it would come up, and that's why I prepared some slides for it. Now, it's very crucial to note that not all exposure results in an infection. The fact that you're exposed to a COVID case does not mean you will get infected. And as a challenge, we've had people who, you know, in the early days of COVID, there were some doctors, once they got exposed, they took time off work and they said, oh, they have been exposed to COVID, they have to quarantine. And then I had a particular case where the man quarantined, the doctor quarantined like 3 times. That's 6 weeks because it goes 2 weeks every time. And then it was the 4th time that he actually caught the virus. And so it's not all exposure results an infection. In an ideal setting, we'll be doing screenings regularly, but it doesn't work. We don't have an ideal setting in Nigeria. These tests are expensive and we cannot afford it. So we really cannot have a test-based strategy here. And as a challenge, we have to be very creative. And that's one thing COVID has taught us, that we don't necessarily have to follow the Western world hook, line, and sinker. We have to look at what works in our environment. We can't afford it. Yes, I know the tests are expensive, but it's because the cost price of these tests are also quite high, especially at some point when the whole world was going for very scarce resources. And so the tests were not, the kits were not in the market, and you have to pay a lot of money. You have to pay a lot of money to get this test done. So the problem, the major challenge with COVID, ladies and gentlemen, is that there is not much value to a negative COVID test. Someone like Trump had been testing on an average 3-4 times a week from February until he was eventually diagnosed positive with COVID in December. If it was an individual doing that, that means you've spent millions on testing before you became positive. So because if you have a negative COVID test, it just means you are negative at that time. And so when a lot of people start coming from testing, especially in this climate where we don't have the funds, then you'll be like, okay, look, this thing cannot work. And so testing has to be based on exposure risk and symptoms. In fact, sometimes we have to be very creative and say, look, even if you are exposed, you are not having symptoms, we know there's asymptomatic infection. Wear your mask, okay, and distance yourself. And then if there's anything, okay, let us know. But we can't just test everybody. For example, you have an event, somebody goes there, in that event, 1,000 people were there, they were exposed somehow, and then all of them come and say they want to be tested. You have to prioritize. Otherwise, you're going to be running out of test kits every day. So that's the challenge. And, also, I remember when we started COVID, the first patient that we had, for example, we tested him every single day, because we were trying to look for viral clearance and all that. Nobody knew much, right? And then subsequently, we reduced the test to testing every 48 hours, then later testing every 72 hours. But now, we don't test anymore. Once you come in, you're positive. We know that 10 days after your first test, you'll be negative, you are fine. And this is something that is worldwide now. I mean, we were one of those that really started it. And then the US picked up because even the US could not sustain those repeat tests again. It was causing a lot of backlog in the system. It was causing a lot of resources were being spent on them. And then data had come out to show that 10 days after you've had your symptoms, even if the virus is discovered in you, you are no longer infectious and everything is fine. So this is very, very crucial because we love tests in Nigeria. Oh God, we like tests. You have the average person going to the hospital just saying, just test, going to the lab and saying, I just want to run tests. No doctor has spoken to you. That's just what we do. And that's what sometimes people try to do with COVID, but that cannot really work. I mean, I borrowed this from Dr. Eric Levi, who is an ENT guy, and he wrote this very popular tweet in July that, look, you can get tested for COVID on Monday, be exposed to COVID on Tuesday, get a negative result on Wednesday. That's about a 36-hour turnaround time. Thankfully, we're doing better than that in Nigeria. And then you meet people on Thursday, you're symptomatic on Friday, you get tested on Saturday, and then by Monday again, just a week later, you are positive. So we tell people that sometimes they can even get COVID from the testing site where you went to do tests. So it's very, very important for us to know this so that we can educate ourselves and educate people and not just unnecessarily clamor for tests. If you're having symptoms, yes. But if you're not having symptoms, it may not be very, very useful. How is COVID treated? COVID, a lot of drugs have been tried, okay? Including chloroquine, hydroxychloroquine plus azithromycin, lopinavir, ritonavir, tocilizumab, and the TNF drug remdesivir, monoclonal antibodies. Many of these drugs have not worked. All these drugs have been validated. In fact, WHO just published a report 2 days ago now on remdesivir that remdesivir is not recommended for COVID. And that is a very, very expensive drug. And people have tried it, but data has shown that this drug is neither here nor there when it comes to treatment of COVID. So COVID has no cure, okay? It has no specific treatment. What we know is that dexamethasone works, and that's one cheap drug that does wonders, especially in people who are on oxygen, okay? We know vaccines are in development. We had very wonderful news this last week. Moderna, Pfizer, they have done vaccines. We're getting up to 90%, greater than 90% effectiveness of those vaccines. We hope that it's like that in real world. We know trial world can differ from the real world, but those are very, very good news. Of course, we know that it's not as if vaccines will come out and reach us today, right? But fortunately, eventually, it will get here. But that's we should know that. And so treatment is really supportive for COVID and related to patient symptoms. And this is why I have a lot of problems, because a lot of people with COVID, especially medical personnel, healthcare workers, they want to just try everything. They want to try everything. They're using this, they're using that, and they just want to use also cocktails and combos. And these things are not data driven. Experience has shown that these things may actually cause more harm. And so we really have to, I mean, it's difficult for you to tell the average Nigerian that you are sick, don't worry, it will go. The guy will be like, okay, like this guy doesn't even know what's going on. And I've had that kind of feedback from a lot of patients. But then after some time, they started trusting our judgment and they saw that on their own, they got better. So for COVID, attack the symptoms and then leave it. The virus will go on its own, hopefully, if the virus doesn't cause a cytokine storm and destroy everywhere. And so that is very, very important, because people are using also some things like Postuma, vitamin C, vitamin D, zinc, very expensive drug. I had a patient bought this vitamin C more than 30, 40,000. I said, well, look, that's what she's going to use. Oh, please go ahead. I mean, whatever makes you happy. But then these things don't work, and then they are causing financial toxicity. So these are things that we really need to follow the guidelines, follow the books, and not just do anything just the way we feel it. So I think at this point, again, we'll have another pause where we wait for questions as we go into the last segment of this discourse. Thank you.
Sorry, I was trying to mute. There are no questions in the chat box, but does anyone have a question, please?
Dr. Ajibade, can I ask a question?
Mrs. Inogbo.
Hello.
Okay, go ahead, Mrs. Inogbo. We're here, we're listening.
All right, ahead, my question is, for those asymptomatic ones and for those that are actually mild, so out of all these listed treatment, will I say trials, or what will I call them, that he has just spoken to us about, how do those ones, how are they taken care of per se? They don't have any symptoms, they are not in any severe condition. So what exactly do they do for such?
Okay, thank you very much,
Dr. Power.
Nothing. I mean, we don't do anything. Again, this is difficult for most people. But what the data has shown, and what from my own experience with COVID, because I have been involved in all levels of management of COVID, I've had people spend so much money. The less you do sometimes, the better. If you are too aggressive with the virus, something will go wrong, and then you're in trouble. So for these mild asymptomatic people, they are fine. Many of them, like you said, they are mild cases. Maybe some of them just have less of sense of smell and taste. They don't have any difficulty in breathing. They have some fever, it has subsided. They are okay. We have treated hundreds of them. We didn't give them anything. When we started, we were also in the same cocktail. We had lopinavir with azithromycin. In fact, it was so bad that HIV patients that were on lopinavir, they ran out because we commandeered all the lopinavir in the town. So you can imagine where we had almost close to 1,000 patients at some point in the isolation centers, and all of them were looking over daily. And some of them can be on admission for 20 days. So you can imagine how much drug was consumed. But then data came out and showed that it was not working. And so we stopped. And we have not had any further. So that is a lot of money that was saved. And that is the importance of having to look at studies, carry out experiments, and see, okay, look, these things that we are doing, are we just doing it, or there's actually a basis behind it? So, for mad people, asymptomatic, like you said, they are asymptomatic, they are mad, they just go on with their lives. The only thing is that they isolate, or they are advised to isolate. I don't know if we don't do it in Nigeria, but they are advised to isolate because those mad people cannot give it to somebody that will now become very sick and die. We have had a lot of that happening. We had a case where a young man came in from outside the country. He had COVID, but it wasn't very sick. But by the time COVID finished in the family, the mother and the uncle were dead. And he was the one that brought it in, because at that point, we had not had community transmission in Nigeria. So we could trace each infection, each cluster. So that's the challenge. So for mad asymptomatic people, they quarantine if they can, okay? Or they wear masks and continue working as much as possible. Because at some point when we had an outbreak in a particular setting, we said, look, if everybody goes at quarantine, the whole day, everything crash. So we just have to say, okay, look, almost everybody's infected anyway. So wear your mask and we continue, and everybody continues to work. Okay, that's not ideal, right? So for the mild cases, no need to take any single thing. They'll be okay. If they want to take something, they can take vitamins. They will be fine. But there's no reason to take anything. Thank you very much.
Thank you. Thank you too.
Thank you very much, Dr. Colin. Yeah. I'm going to call one or two people, but please, you have to be very brief with your question so that we can finish the next.
Hello, good afternoon. Can you hear me?
Yes, I can hear you, sir.
Yes, go ahead, please.
Okay, I just want to ask, in our hospitals, in Reddington hospitals, we, before that, I want to say, well done, our presenter. Thank you. We've learned a lot so far. So my question, we used to man people in front of our hospitals to, use questionnaires and check temperatures for patients coming in, so that at least we can be able to triage those that are, of high tendency of having COVID. We can isolate them outside and, send them to the appropriate quarters for management. So right now that some people are asymptomatic, and sometimes some people don't present with the usual symptoms of COVID. Many people outside the hospital, is this still very necessary? Do we still need to do that triaging, where we have to place a nurse or a medical staff outside to check temperature and ask questions with questions necessary at this time? That's my question.
Okay, thank you very much for your question, sir. Okay, so I think that actually you have preempted the next part of the lecture, which now we are coming to the hospital setting and say, okay, what are the things we are to do? What are the things that work? What does not work? So that's the next thing we are talking about. So I believe your question will be appropriately answered by the time I talk about that. So I don't want to, so that we can have other questions now. But I believe if I don't answer your question, then maybe just let me know by the end. But I've already prepared slides on that. Thank you very much.
All right, thank you. Paul Opara, please. Go ahead.
Yes, my question is about the testing, because from the presentation, I heard that if your temperature is above 38, consistently you need to get tested. So is there any particular designated places where we can actually refer people? Because it's not all about health workers, because the exposure, when we leave our workplaces and go home, we are also exposed there. And sometimes we encounter people who are always coming up with all this complaint. What do I do? So is there any place where they can easily walk in and get this test done without even paying? Because that financial burden is also part of the factors that are restricting them from getting tested. Thank you.
Okay, thank you very much, sir. So what happened is that the state created walk-in sites at all the LGs where people can walk in and get tested. Those working sites are not currently they are not currently manned now because so the challenge is also that this is almost becoming more of an endemic issue, and there's a bit of focus away. The focus is shifting away now. So, but people can still get tested. If you They're still testing in Yaba every day at the Lagos State Biobank. So that's the headquarters of the testing for the government. So, but at the height of the pandemic, we really had these places in all these LGs where you could just walk in and get tested there. Like I said, the challenge with this testing is, because a lot of people come to my place for testing and then you tell them, don't worry, you'll not get results. So we just tell you what your result is, or we send it to you as a text message. And then they say, oh no, they are not doing it. And that's when you know that, okay, probably they needed a test to travel or something. So that's the issue. But yes, I think I would just recommend that anybody that wants to test as part of surveillance, number one, two things, you can call the 8000 Corona number. If you call the number, then they will go to put you through the process, and there are still teams. We still have rapid response teams that go from place to place to do investigations, outbreak investigations. They are still there, though they are skeletal. They are not as strong as during the peak of the pandemic. But if you have anybody that wants to test and really has issues, they can go to Yaba, please. They will test them free of charge, so long as they are surveillance-based testing. Thank you. Sorry, I think we have a question. There's a question in the chat while probably we're waiting. Okay, so that's from Toluwala Abraham. He said, thanks for the lecture. Thank you. Please, are there other things that help us in the clinic to heighten our level of suspicion since the symptoms are somehow non-specific, like SpO2 or full block or CRP test? Yeah, that's a question that doctors have been trying to ask all over the world. And, the challenge is, we always tell them that COVID will always disgrace you if you are not careful. Because there are times where we try to bet and say, okay, this is not COVID. This is not COVID. Okay, let's just go and test. And then the result comes out, it's positive. And then sometimes you come and say, no, I can bet my salary, this is COVID. And then you do all the tests, CT scans, and everything comes out negative. So it's neither here nor there. We know in public health, you rather err on the side of caution. So it's better you cast a wide net and have more false, so-called false negatives than for you to have false negatives. But the thing is, of all the things you mentioned, the most helpful is probably the SpO2. Right now, you have anybody saturated at 88, 89? Let's check. Let's check for COVID. In fact, so what we do, you might say that because labs can be very erratic sometimes. I mean, at best of times, you could have run out of reagents and all sorts of things, and turnaround time, best you get is 24 hours, sometimes, or 6 to 8 hours. It's long, depending on the time the person comes in. So what we do, we have a suspicious case, based on the clinical features. We look at the SpO2. SpO2 is low. We take the patient for a CT scan. We've seen that the CT scan is very good in picking our cases, and the CT scan, you get the results on the spot. And so a lot of times you can make that decision as to whether this patient is going to enter the hospital or we're going to put him in the isolation center. So the CT scan really helps. And then when you lose, so it's not just one thing, it's a combination of different things that you're using your clinical acumen, you're taking your history, you're looking at other conditions, and then you're looking at SpO2, and then you do a CT, and then hopefully you still do your lab test, of course, that's the gold standard. But you need to make a decision, and those things help you to make a decision as to where the patient will go. Thank you very much.
Thank you very much for those questions, everyone. And thank you, Dr. Pawai. So I think now we can continue to the final stage of the presentation, and then we'll be able to take the questions afterwards.
Okay, thank you very much, Dr. Babajide. So we just fly through the rest now, and we'll talk about preventing COVID in the hospital. And again, probably I don't know, maybe Dr. Luwale saw my slides. I know he didn't. Well, of course, he's a senior man, and he already alluded to this, talking about the hierarchy of controls of hazards. And like you said, PPE is the least important. I mean, one of the things you try to do is to see if you can eliminate the hazard, and that's what we're going to be talking about. Like how can you take out the hazard totally? You don't expose more people, and that's the most important thing. If you can't take out the hazard, is best. We can't substitute the hazard, or maybe we can, in such a way that, okay, this patient should go to this place, with the other patient should go here. Engineering controls has to do with our ventilation, in the hospitals, which we need to use a lot of HVAC and EPAS filters to help with that. Administrative controls is what we are doing now. Training. We have to change the way people work, and this training is very, very crucial, because you can give people all the PPE in the world. If they are not trained, it's a crisis. We all remember this guy from the movies, probably the best-selling series of all time so far. And sometimes COVID feels that way, like Thanos. I mean, like his famous quote, "I am inevitable." He would always come in, and despite all the things that were done to try and stop him, it still happened. They actually had to go back in time and all that. And sometimes COVID is like that. Why am I saying this? Is that regardless of whatever you do, you're going to have exposure to COVID. Now, what you do after is what determines whether you're going to have an outbreak and it's going to mess you up, or it's just going to be an exposure and you're going to deal with it. So the recommendations, sorry, I wrote for school here, but physical distancing, ventilation, masks, I won't be able to go through all this, okay? So, but there's something we call the Swiss cheese model of hazard control, of prevention, which states that, I mean, only one thing does not work. For anything to really, you have to go through so many, there are so many layers to this, and you have to do multiple things, and like the Swiss cheese with so many holes. But the more you have this, the more layers you put in here, the more likely that you are going to be protected at the end of the day. And you can see it's physical distancing, mask, and hygiene, all the things I have in that list, okay? And then the things from the government. And then by the time you match all these things together, it would help. Now, I love this graphic because it showed what we call personal responsibilities. There are things that you have to do on your own. Nobody's going to force you to wear a mask, especially when you're not in the hospital, especially when you're not where you're not where a supervisor can see you. Okay, those are personal responsibilities. Physical distancing. I mean, you can leave the hospital and go to a club, and nobody's going to police you up to that extent. So we have to take this responsibility. I mean, be responsible. I mean, like the SCDC says, everybody has to be personally responsible. There are things that the government will do. There are things that the hospital will do. There are things the authorities will do. But a lot of things that we have to do on our own to make things work better. Okay, so this is just a close up of the Swiss cheese, and most important for COVID is the distancing. I always tell people, if all of us can sit in our houses, lock up the doors, and eat, we have all the food we can eat and everything, we're going to be fine. We don't have anything to fear from COVID, right? But but that is not possible. We have to eat, we have to work, we have to save lives. And so we may not be able to do all of that. So we have to be very, very creative in trying to see how we can protect ourselves. Ventilation is very crucial with COVID. It's a respiratory virus. I recall an hospital where they had an outbreak. One COVID case went into the hospital. By the time we were done, we had more than 30 cases. Why? Because like most buildings in Lagos, it was just one giant box, okay? And it was the same ACs, huge vents connecting everywhere. And so the virus just traveled through all the vents, and it was not good. It was not good at the end of the day. So ventilation is crucial. Of course, the masks, very, very important. After the mask, we have things with hand hygiene. Look at where testing comes in. Look at where testing comes in. Far after all those things. And that's why I keep saying that testing is not the way to go, especially in a place where we cannot afford it. That's the truth. So we really have to be very creative and try to do so many of these other things before we get to testing, even though we know that the testing is the only way to really be sure that there's COVID, whether there's COVID or not. So like I said earlier, insidious nature of COVID-19, especially with all these asymptomatic patients, means that exposure is inevitable. And that's one thing we have to know, so that when these exposures happen, we don't set up a firing squad and start saying, oh, who messed up? Oh, why? Who dropped the ball? I mean, regardless of what you do, if the COVID entered the White House, COVID entered Astro, COVID was down the street, you can see what's going on in the US. So you're going to have an exposure. You're going to have it. It's inevitable. And so we really have to know. It doesn't mean that we should throw up our hands in the air and say, oh, there's nothing we can do, we give up. No. But we have to be careful in addressing these issues when they occur. Because even that patient that is clean and everything was perfect at the time the patient was coming in, there is no reason why the patient cannot develop an infection while he's in the hospital. And I've seen cases of that. that the patient is fine today and then became sick 5-6 days into the admission. Okay, so but what we know is that once you have this training, a quick response can limit the damage. You understand? It can minimize the damage and curtail a full outbreak, deal with it immediately, and then you are out of it. And that is why you must have an emergency response plan. Of course, physical distancing, like I said, is key. It must be observed as much as possible. This one, we are very poor with at it as doctors, as nurses in the healthcare. I mean, we still have very crowded call rooms, so you wear the PPE to the patient, and then we get into our own space, we throw caution to the wind. Like I said, the very first doctor that died actually got COVID from a doctor's conference in Lagos, and so we have to follow the rules we place on others. Online meetings like we're having now should be encouraged where possible. Some things cannot be done online. Where you have to do it, you have to give your spacing. And people have been very creative. I mean, there are places where you have bubbles. You have times where a particular shift works this week, another shift works next week, just to reduce and decongest the office space at any particular point. So let's talk about screening, which is a very poignant one. And that's a question that has been asked. Now, all individuals entering the facility must be screened for COVID symptoms. We are back there. I know we were doing it at some point. Everybody has relaxed now. But ladies and gentlemen, we have the second wave. We have to be careful. Even though, well, most of us have gotten infected by now, whether knowingly or unknowingly. And we have some level of immunity, but some others have not been immune, and we have to protect them. Okay. And when I say all individuals, I mean all patients, visitors, and personnel. Again, we make this mistake in healthcare. I mean, there's just this innate arrogance with healthcare workers, like, oh, there's nothing wrong with me. And so we have had hospitals where they had all the screening for the patients, but their own staff, they go to another door, they just enter, nothing, no checks, no balances. When they would have COVID, it was their own staff that brought it in. Okay, came in with fever. Nobody even thought that it could be COVID. They just, malaria, and then before you know it, wow, crisis. A whole place blew up, and the hospital had to be closed down because they just had almost everybody was infected. And so everybody must be subjected to these processes, okay? Whether patients, visitors, or personnel, and you try as much as possible to stop them at that point, because at the point these cases get into the hospital, things have already gone too far. I mean, like the Yorubas will say, the maiden has already walked naked to the market. It's already late. Everybody has seen her in that state. So the whole idea is to stop, okay, do the screening. If you pick up a case, isolate, have an holding area where you keep the patients. Again, the challenge we've seen in so many places is that, yes, they are doing the screening, but they don't have any plan. I've asked front desk personnel, I've asked security, okay, this temperature you are checking, what if I come in with, or what if the patient presents with this? What are you going to do? Okay, you know that. And then, okay, so I went, so what happens? Nothing, no plan. And so it's very, very crucial. I mean, thank God we have, we need to have these emergency response plans as to what exactly is going to happen. Okay, so the hospital should have a closed entry as much as possible. You shouldn't have people be able to just walk in. I mean, we had a case in Bagada then, in one of the hospitals there, where three foreigners just walked into the emergency in the middle of the night, and one of them started coughing immediately. Of course, cue the pandemonium. Everywhere just scattered. Okay, so we must have this security sort of people can't just walk in, into the hospital as much as possible. Even if it's an emergency, you should have they stop, you screen them, and then they move in. For clinic visits and appointments should be made, and screening can be done via the phone even before the patient comes into the hospital. So that's the best. That's the most secure. You are not seeing the patient is not seeing you. Ask all these questions. We know people lie, right? But at least we still ask. And the way you ask these questions, you know whether you're gonna even ask the patient to come to the hospital. You just do your telemedicine, and the patient doesn't have to come. Temperature checks should be done, but must be noted that they are notoriously unreliable. Temperature checks, if you use the street, you get a speed. I mean, we've all been there when somebody will check you in front of one supermarket or something, and they'll tell you your temperature is at 2.1. And we're like, how? This is not even compatible with life. So some of those machines are notoriously unreliable. A lot of people using them don't know how to use them properly because they are not putting them on the right spots or something. As a clinician, I don't trust those things. I use my normal, the one I put in the mouth. I prefer those ones. Okay, so the temperature checks, they help to catch some cases, right? Because at least anybody coming with high fever, you're going to isolate them immediately. But must be noted that we can't really rely on them too much. But does not mean that they should not be used. Okay, patients can be screened in their cars or screened in flights. Okay, because it's also important that when we are doing the screening, we should not create a congestion at that point, because it's not everybody that will come with COVID. So when you're doing the screening, all of them are mixing together. Even that person that you think does not have COVID may have contacted it at that screening point, and then there's a crisis. Okay, so and all these policies must be clearly communicated to all staff and patients. We know the kind of clientele we deal with, and it's very, very important that they know that this is the new policy because of what is going on and all that, especially at the point now where restriction seems to be waning all over and people have thrown all caution to the wind. So it's going to kind of be a kind of aberration. And so there's more education that needs to be done on part of the patients. This is an example of a screening tool that we can use. And then, I mean, studies have been done to show some of these things, that what exactly works and what does not work, but that's a screening tool that we can use. Again, I've said it before, many health facilities fall into the fatal flaw of screening patients without any attention to healthcare personnel. Okay, so everybody must be screened. Even the doctors could get COVID. A lot of them have gotten it, so they should be checked. Okay, and healthcare workers, they should self-monitor for symptoms. So there's a lot of personal responsibility that we have to take care. So that if you know you're sick, then you try and stay away. But at this point, you need to discuss with HR, because then people are afraid, especially when you are paid on a daily basis. Oh, look, if I don't come to work, I don't get paid. And then there's a crisis like, look, I'm not that sick. That the sort of is going. I can still come. And then, like I said, you can come transmit it to somebody who will become very sick. This is a study that was done in King County in Washington. It was published in JAMA, Journal of American Medical Medicine. And it was symptom screening at illness onset of healthcare personnel with SARS-CoV-2. And when they looked at the symptoms that they presented with and the eventual positivity rate, you see that the more symptoms they have, the higher the positivity rate. When you combine so many, you don't just say fever, but when you look at, say, fever plus cough plus shortness of breath plus sore throat, myalgia, by the time you added all that, you got almost up to 100% correlation between the symptoms and the eventual test results coming out positive. Now, the funny thing about this study is that about 64% of the people in this study, even when they were sick, they were still coming to work up to 2, 3, 4 days after they became sick. So this is not just a Nigerian issue, it's a worldwide problem, and we have to be very creative in solving this problem if you really want to limit the spread in the hospital. Let's look at visitors again. Like I said, all kind of people entering the hospital, whether they are visitors, they are personnel, or they are patients, all of them must be screened. But this is not a time to encourage visitation, except it is absolutely necessary and it must be restricted. We know, I always say the southern part of the country we're enjoying. I've been to the north where one patient can have 40 visitors. 40. If I've been there, it's not an exaggeration. 40 visitors, and we can't allow that now. Okay, so visitors must be severely restricted, and all the visitors that come, they must also be subjected to the same processes and protocols as staff and patients. Another very important thing, is the masking policy. And masks have been shown to help because it's difficult. Okay, but we know that when you use masks, things are better. Okay, now all patients must be on face masks as much as possible, as much as can be tolerated. Okay, and when patients are on masks, they should use the surgical masks. Please don't put patients on N95. It is inhumane. Okay, because that mask is constricting even for a normal person. Not now talk of somebody that probably has difficulty breathing or has some other condition. Okay, so but as much as possible, they should be on mask as well tolerated, as more as they tolerate it. Okay, all visitors must be on face masks. All healthcare workers must be on face masks. And for these masks to work, they must be worn properly, consistently, and removed properly. Okay, of course, for the surgical mask, we know they have two sides with 3 layers. Okay, and again, we see this thing of people wearing the white side outside. Of course, it's not true. Please, we should have gone beyond that. Now, these are the 3 layers in a normal mask. That's how it should be. So masks should be changed if wet or visibly soiled. Remove without touching the front of the mask. Do not touch your eyes, nose, or mouth after mask removal. And as much as possible, practice hand hygiene. Many, many, many people, including doctors, nurses, they don't wear masks properly. Many people put it on their chin. Many people, their nose is showing. And those things don't work. The whole idea of PPE is for PPE to be used well. If they don't use it well, then there's no point. And it's very, very important. There are so many ways not to wear a mask that people do. I mean, people, a lot of times people do this, where they just bring the mask down probably to eat or to talk or to laugh or whatever, and then they spew all sorts of droplets at that point. And so we really need to have strong measures in place, especially because we know we are working in high risk environments. And as much as possible, the only time you can put down your mask is when you are not with anybody. You are alone somewhere, or you are in a free space, you are all alone, then fine, you can pull down your mask, and the mask should be pulled down properly at that point. Of course, N95 mask should not be worn routinely, should be reserved for aerosol generating procedures. And the N95 with exhalator valves, like the one on the right, should not be, they are not good for source control, because those exhalator valves, the whole idea is for them to allow the person to breathe out, because N95 can be very constrictive. And so when the person is breathing out, if it's the one that has all the virus is going out. But it's a one-way valve. The virus will not come in, but the virus can go out. So you can't allow, especially visitors or patients, people that are not sure of their status, to wear this. Okay? So, but like I said, I mean, the thing looks sophisticated. So you see a lot of politicians wearing here and there and stuff, but it's not recommended by anybody. It doesn't work as well. Hand washing is something that's also very, very crucial, and probably that's the last thing I'm going to talk about because of time. Hand washing is key, because not only because of COVID, but because so many infections are transmitted by the hands, and more hand washing we do, the better we reduce hospital-acquired infections in the facility. Hand washing, of course, soap and water is preferred if available. If it's not available, you can use alcohol-based hand drop or sanitizer. And of course, using soap and water 40 to 60 seconds, alcohol-based hand drop or sanitizer 20 to 30 seconds. Again, hand washing is another thing that people don't do very well. There are several places that must be washed. All these places must be washed as much as possible. And I love emphasizing hand washing because, like I said, it prevents so many HAIs, hospital-acquired infections, not just COVID. And it's a very, very good practice for us to have hand washing stations, have hand washing principles, have hand washing monitors, because when we do that, it will really improve the welfare of the staff and the patients. And these are all the steps of hand washing that we should know and we should go through. But again, this is better done in a face-to-face teaching, or at least in a practical class where we're seeing videos and all that. So the reality, ladies and gentlemen, is that we are still in the throes of the COVID-19 pandemic. We cannot be deceived. The threat is not gone. We still need to be careful and observe safety protocols. We can't fall into the risk of pandemic fatigue now. We are working in high-risk areas. The war is not over. We should all be careful, and God will keep, He has been faithful, He has been protecting us, and will continue to do that. Thank you very much. These are my references. Thank you.
So thank you so much, Dr. Opawe. I mean, right now, this brings us to the end of the presentation, and then we will be able to take questions. But you will kindly do us a favor. Okay, I can see a couple of hands raised. So we will raise your hand, and then we will take your hands in that order. Opera Paul, you've asked a question. If you're still raising your hand, you will be called, but otherwise you can lower your hand. So right now I will call on Obi. His hands have been raised from the previous QA question. All right, Obi, go ahead, please. Obi, you can ask your question. Okay, while we wait for him to get ready, I will take Benga Samuel Orisome. You're muted. Go ahead, Benga. Okay, we will have to move on to Dr. Okongo. Dr. Okongo.
Good afternoon.
You're welcome.
Everybody.
Happy married life. Congratulations. Ask your question, please.
Thank you, ma'am. Okay, so I just want to make a quiet observation from the very first aspect of the lecture where the speaker was talking about the workers in the hospital who were more at risk of infection or even infecting others. And of note were the health assistants, the assistant workers, the nurse, the care assistants, the cleaners. Now I want to make a quiet observation. I'm almost sure that on this meeting, fluorosil is not on this meeting. And these are the people who will clean, who will touch the door handles, who will take their used glove from one room to another, use it to touch the door handle. So my question is, what are we putting in place to see to it that the cleaners, the healthcare assistants, who everywhere in the world we know that the ones are likely going to get the least training and they're the most important portal of infection in a health facility. What is the plan to see to it that there's training and retraining for those people? Thank you.
Hello. Dr. Babajide, I think that question was meant for you.
Hello, Dr. Babajide, are you with us?
Oh, there. Hello. Hello.
Hello, yes, we can
I
hear
didn't
you.
realize I was muted. Dr.
Oh,
Kwawe,
sorry.
I was speaking for 3 minutes. I didn't realize I was muted.
Oh, sorry, you were.
What I said, Dr. Kwawe, let me see you. And I was speaking. So I will go over it again. So Dr. Chidima, thank you very much for asking that question. I will say that with regards to this training, the invitation was sent to everyone, like I said earlier, from the senior management, from the most senior to the most junior. So if fluorosil was not here, then it's going to be that the information was not passed across to them from the leadership. Not only was everybody informed, several reminders were sent again and again. So we were looking to that. Now that is for the training. With regards to this training, everybody was invited to this training. And you will also notice that we are streaming live. This training has a capacity to take 300. We are over 700 staff across the Reddington Hospital group. The attendance is poor. But what we have done is just to make sure that everybody is accommodated. We're streaming live on YouTube to make sure nobody is left out. So we really made adequate preparations for everybody to have this training, right? So, but we're looking to make sure. Then also, furthermore, it's going to be recorded. So if at all they missed it, or any of them missed it, it will be passed on to the leaders in the team to make sure that all of them be training. Now, with regards to retraining, we've done some trainings for them before now, and retrainings have been done. However, in the last 2 to 3 months, we haven't had any training. So this is why we are having this. And hopefully going forward, that's a lesson we've all learned. And that's what we've all agreed. Going forward, we're going to be having frequent, will be hear me? I lost internet connection for a bit. So the trainings will be available to them, and we'll make sure, Dr. Chidima, thank you for that observation again, that all of them are up to date with regards to the training. Thank you. Is Samuel ready now? Samuel Orisomi. Dr. Obi, are you ready? I don't know if that's Dr. Obi or another Obi. Obi, you can ask your question. Okay, right now, okay, Benga is ready.
Yes, thank you for the presentation. I had where I previously, the isolation center I previously worked, I had like an argument with a doctor that I foresee in the future that with the financial demands that this virus comes with, that and especially for the common man to get tested and get treated, that there might be a time where COVID might be treated like malaria. So I just want to ask, is there a possibility that in the future, blanket treatments might be instituted? Because if you want to treat somebody for COVID now and you are insisting for a test to be done, the person may not be able to afford the test, to afford the testing. So in the case of any suspicion of COVID-19 infection, is there a possibility that there will be kind of a blanket treatment?
Oh, thank you very much, Subenga. Now, look, I'm a bit challenged when you say, what do you mean by blanket treatment? Like what exactly are you giving? What are you treating?
Okay, like sometimes you use broad spectrum antibiotic, sometimes you can use some antibiotics even for some suspicion of maybe without isolating an organism. You can use the broad spectrum antibiotics. So in that light,
Yeah, I understand. Antibiotics, not antivirals. Again, there is no treatment for COVID. Up as EOZU now. We don't have a treatment. Maybe later, right? But now, nothing. Viruses are notorious for that. It's difficult to make antivirals. I mean, remdesivir now, WHO just slammed them. And I mean, remdesivir was initially developed against hepatitis C. It failed. And then they went and tried to use it for Ebola. It failed. Now they have used it for COVID. I think the drug just cost or something else is wrong. It has failed again. So antivirals are very difficult. Antibiotics, yes, for bacterial infection. But like I said, over and over, COVID does not have a treatment. So when you say somebody has a suspicion of COVID, people come to me with that a lot. I just said, fine. Okay, no problem. Isolate, wear your masks, you're good. If we can test, fine. If we cannot test, in fact, some people I tell them, don't waste my kids. You call me, you are saying you cannot smell. I say it's not malaria, it's not typhoid. I mean, one of the very few conditions that cause loss of smell is probably Parkinson's. Or maybe you have a tumor there or something. So it's not very common. So you cannot smell, I tell you, you're positive. There's no point testing except you just want it for scientific or for record purposes. Okay, go hydrate, drink your water, eat good food or whatever, you'll be fine. Check your pulse oximeter. Okay, and that's what I always do. Always monitor your saturation because we have this issue we call silent hypoxia or happy hypoxia. We've had patients with saturations of 85 that didn't even know that they were breathless until they got into the hospital. So I tell them, check your saturation. If you have your saturation, you are fine. There's no problem. So please, there's no treatment for COVID. There's no way to say you're instituting any treatment for it. You can just monitor, and then once the patient deteriorates, then you can treat and give dexamethasone. Otherwise, most people are going to be fine, and then you treat the symptoms as they appear. Thank you.
So for those that are not hospitalized, that at home, would you recommend that they have a pulse oximeter if they have suspicion of being infected by COVID?
Yes, sir.
I mean, because if there's
yes. So what I do, and is what we do a lot of times is once they call in or we diagnose them, we stopped admitting everybody in the States a few months ago because we're just getting overwhelmed. And so once they are not very sick or they are mild cases asymptomatic, because we know mild cases can become severe. So what we do is to recommend that all of them should buy pulse oximeters. So they buy the pulse oximeter, they check the readings, and they send it to you. So there's a monitoring system where they send it every day. And then immediately when there's a crisis, we're able to trigger early and take them and put them in the isolation center on oxygen and all that. But a lot of times they are fine throughout, so long as it's not below 94, they are good, and then they get successfully managed at home. Thank you.
So at what point are we sure
right.
that
Benga, 1 minute, Dr. Powie, 1 minute. I will just indulge me for a couple of minutes and then you can go ahead. I want to recognize the presence of the CEO. Remember I said we send invitations to everybody from the most senior people in the senior management team to the very junior staff. I didn't even realize the CEO himself is here. So we have the CEO with us. Apparently he's been with us all through the training. Thank you for being here, sir. You're welcome. All right, Benga. Dr. Power, you can go ahead.
Okay, I was going to ask, so for those that you tell them to stay at home and get better, at what point can we say that they are negative in COVID? But what's the assurance that?
Okay, so what we know from studies, again, these are not arbitrary decisions, is that if a patient is not very sick, that is mild or asymptomatic, 10 days after his positive test, he is free of the virus. If he's symptomatic and he has mild symptoms, again, you use 10 days, so long as he doesn't have fever. If he has fever, you add a day to every day he has fever. And then after that, they are fine. So we don't need to do this. So what we do, we calculate. This person got tested on this day. We look at the day the symptoms started. If it's somebody that has symptoms, 10 days after the onset of symptoms, we know that the virus has passed and they are no longer infectious. If he doesn't have symptoms, then we use the date of the test. Thank you.
Sorry, I was muted. Dr. Kwawe, somebody's asking a question on the use, on your take on using 2 surgical masks. Joshua, I hope I'm asking your question correctly.
Yeah, thank you, Joshua. A double surgical mask is
you answered.
Yeah, you wasted the second.
I can see your answer now.
Yeah. But now for people who are using the now, because COVID has taught us all sorts of rigmarole in this business. Now, for people who are using the N95 with the exhalator valve, those ones that have the valve in front, we recommend that they cover it with a surgical mask. Okay. And then sometimes when you have issues with the N95 and you want to use it for an extended period of time, you can wear the N95 and wear the surgical mask over it to sort of protect the N95. And that way we have successfully used N95 for weeks like that, especially when we're going through severe shortages. So you can wear 2 masks, but not the same type. And those are they are just, cutting corners and trying to, just extend the life of the mask or trying to give advanced protection. But 2 surgical masks is just going to make you really suffocated. And at the end of the day, we actually think you have COVID by the time you develop difficulty in breathing. It is not recommended. It doesn't offer added protection. Thank you.
All right. Does anybody have any more questions? Obi, your hand is still raised. I think
there's a very interesting question here. Dr. Wajidi,
okay.
He said,
yeah, let's see.
Also from Joshua. Joshua says, I understand that health records should be kept private. Do you think other colleagues should be informed when a member of staff gets a positive result for the purpose of contact tracing and surveillance? Yeah, I think so. I do, because We have a lot of confidentiality in medicine, but when it comes to issues of public health, then confidentiality takes a backseat. Especially when that information is going to be detrimental to other people. I mean, it's been very difficult with COVID because a lot of the people that had COVID initially were really, really high top people in the country, and it was at the point when it was a stigma to have COVID. It was believed that maybe you have offended the gods or something is wrong with you, and so there was a lot of secrecy involved. And I know cases where people had COVID. They didn't want anybody to disclose. They didn't even disclose their contacts. But there are really no secrets in the world. And so eventually when the story broke, but when it leaked that they got COVID, somehow, some people had, of course, the contacts were not happy. So that's the challenge. So if a member of staff tests positive, then the people that need to know should know. It doesn't mean that the person has to be put on a placard or a billboard, but for contact tracing, people must know why they are getting tested. And you have to tell them, okay, look, this person was positive. And I know there are a lot of mental issues that could come with COVID. I mean, things are better now, guys. In those days, it was bad. It was bad. But things are a bit better now. We had people who were chased away from their homes because of COVID. When we carry the ambulance to go and take people from their houses to the isolation center, as you are going, they get mark pada, wow, don't come back, just go like that, And then there was actually some people that the state had to provide housing for them because they warned them with death threats if they come back. Because as far as the community was concerned, they were not free from the virus. So those are some of the mental issues that we have to deal with COVID, the stigmatization. Some people will come back to work, they will not be reintegrated, they will enter a room, people will leave, just because they were positive before. They say, how do you know it's still not positive? And all sorts of things. So, but results should be disclosed and everybody should handle it maturely. Thank you.
So, I will ask this question, right? And for everybody to listen and hear. What's your take on web establishment? I know that WHO, the CDC, and even the Nigerian CDC have said that for healthcare workers that tested positive, like you quoted, 10 days after symptoms, they can freely come back to work because they are no longer infectious. And for those that have severe disease, 20 days after onset of symptoms. But we are a private organization. And don't forget that we may have some really highly placed clients, even if they are not. Do you think, and so one of the some of the worrying things have been, and for those reasons, a couple of staff that tested positive and were still tested positive, have been asked to stay back home. And as I speak to you, we still have 2 of our medical staff still at home because they tested positive 14 days after. So what do you take?
Okay, thank you very much, Dr. Babajide. So one of the recently we're asked to talk about our challenges with COVID and the challenges we've had in just running things on a state-wide basis and a national basis. And one of the major problems we've had in Nigeria was failure of people to follow guidelines. Especially from senior doctors. You have all the guidelines, you have all the studies, and then you come, okay, look, this is what this guideline says, this is what we are following for. And they say, no, forget it. It's nonsense. We are going to do what we want to do. So if the guidelines state something, and that's a challenge. If the guidelines change, we change. If they don't change, otherwise, it's just going to become chaotic. Now, what we know from the guidelines, and I have personally, because this is a general problem. There are companies that insist that they must come with 2 negative tests. Some will say they must come with 3. Some will say if they don't have a negative, they should not come back to work. And then at some places, companies, people they stop their salaries. Now look, they have been at home with this COVID for 1 month. They have tried for them. If they are still positive, then that's their problem. But studies have been clear. Almost 10 studies have shown that even if they are positive after 10 days of a mild illness, when you take that virus and you try to culture it, it does not grow. So they are not infectious, they are just fragments of the virus. They cannot form a whole virus again. That is what we know. So what I tell people is don't even do the second test, because then the mental issue now comes in, the mental breakdown of, oh, how am I still positive? And then but 10 of us were positive now. It's only me now. Is there something wrong with me? And then that's when people start to go and start using all sorts of things, because they believe that. And then somebody will say, oh, don't worry, did you use dogoyaro? Oh, it's because you didn't use dogoyaro. I used it. That was why the virus died earlier, and come with all sorts of old wife tales. So we must follow the guidelines. And when the guidelines change, we change. Now, there are cases where we have to look at things on a case-by-case basis. So, for example, if you have somebody in the isolation center, and we've had those kind of things before, where the person comes into the isolation center and then is going back home to a 70-year-old mother, 75-year-old father that has had a cancer and all that, then at that point, we want to be sort of extra sure that this person is definitely no longer infectious. Or you have a doctor or a nurse or a healthcare worker working with oncology patients or radiotherapy or chemotherapy. Then at that point, we want to be double sure that, okay, look, before this man goes back to dealing with these transplant patients or highly vulnerable population, we want to be doubly sure. Then we know the studies are a bit silent on people who are very sick as to how long they take to eliminate the virus. In those case-by-case judgments, then we can say we need negative tests before this person can resume. But for the run-of-the-mill normal person, it is a waste of resources, it is a waste of funds, it's a lot of mental pressure on the individual, and it is absolutely unnecessary. Thank you.
Never do.
Yeah, Dr. Kwawe, somebody actually wants you to speak on stigmatization. Hold on, let me read out the chat. Okay, and that's from Dr. Shibamawa. He's the medical director for the VI branch, about COVID-19 and stigmatization. I think you spoke about it in the course of your presentation, but I think if you can speak more on COVID-19 and stigmatization. Then there's another question on the role of vitamins, zinc, macrolides, and other supplements as prophylaxis. Now, I'm not sure you mentioned this as prophylaxis, so also pass a comment. And okay, you replied. Brilliant. Okay, I can see the reply. All right, thank you, Dr. Kwawe.
Okay, thank you, Dr. Shibamawa. So, I mean, I think I would rather give leave for the experts in mental health to talk about stigmatization with COVID, but it's a big issue. Of course, I was stigmatized, but I mean, for some of us, it's not new. I mean, I've chosen. I first had a foray into infectious diseases when I took part of the Ebola. I was part of the Ebola crisis then. I was probably the second indigenous Nigerian doctor to work in the isolation center because, of course, nobody wanted to show up. And Ebola is far more deadlier than COVID anyway, with a mortality rate of about 50%. And I recall back then that, you know, when people got to know that, okay, that was where I was taking care of Ebola patients. Then I'm walking on the corridor and people start crossing to the other side. And people start crossing the other side. I mean, nobody wants to greet you, nobody wants to touch you, nobody wants to argue. At those times when there was even no restrictions on all these activities, okay? I remember I was in a particular medical meeting in the hospital, and I think maybe I sneezed once. That was in 2014, and somebody, I mean, one of my professors was like, okay, yeah, I think you can go. Don't worry, just go home. Take 2 weeks, you can go. They didn't want to see me. It was, well, it didn't really affect me because, well, it was more free time for me anyway. But then, yeah, stigmatization is a big problem. And like I said, with COVID, it has been very bad. We had people who lost their jobs in the isolation center. I mean, some of them we had to get the Ministry of Justice involved, and so many issues come up. I think things are better. At this point, most people have gotten infected. It's no longer, and really, I really appreciate those that spoke out in those days when it was not popular to speak out. I mean, one of the people I managed somehow, that was the actress Omotola, you know, when she was sick, and I recall that she went and she spoke that, okay, look, go, this COVID thing is real. I've been diagnosed with COVID. I've been very sick and everything. And the backlash was so strong. I mean, she told me then that people came and accused her she had collected money from the government. She was part of the scam. And look, you are just lying. And that was somebody who was vilified for saying she had COVID, that she was lying. And then some other people have believed the extent of people running away from them. So we had families that were broken because of COVID, because the husband was positive, and the first thing the wife did was pack out of the room. Just say, look, I think I'm not coming back. Or the husband or the wife is positive, and then the husband says, look, you must go to the isolation center. I say, okay. They said they are not admitted symptomatic. They say, no, go, don't kill all of us. And then we've had medical and non-medical families where there was a lot of finger pointing as to, you brought COVID into this house. I've always told you to be careful. You're not careful. I told you to stop going to work. So it's a big issue. It's a big, big, big issue. And some of the effects is going to take some time before really understand the full spectrum. I think as healthcare workers, we should just try and go out of our way and be understanding, especially when we've had exposures and people have been positive and they are coming back to work. We should try as much as possible, even with all the limitations of distancing and all that. I've had to hug people in this COVID, right? Because just to make them feel like they're still part of this world, So I think we have to be personally responsible for that. And we also have to create company policies to try to make the integration easier and seamless for people who have been positive. And the more we have the bosses, the managers coming out and speaking with these people and siding them and showing that, look, I'm working with this person, there's no problem. It sort of helps the younger people to become more comfortable. So I think it's a major problem. I think it's better than where we were in February, March, April. And I think there's still a lot of work that can be done in that area as to making people that have the virus to know it's not a death sentence and they should feel comfortable with it, especially when they have recovered, and they should be reintegrated successfully back into the system. Thank you.
Yes, thank you very much, Dr. Powe. I'm not sure there's any more question, but I will say one or two things and then have Dr. Ejima can speak. And we'll allow the CEO say something to us before we call it a day. Now, with regards to a couple of, I'm sure all of us will be wondering what management has in stock. Now, what if I'm COVID positive and I become very sick? What happens to me? So number one, like he has said, when you get exposed, we look out for symptoms, and we're going to be sharing these guidelines with us all. We look out for symptoms. The QA team monitors you. If you develop symptoms, then we pick out those that need to get tested. When you get tested and you test positive, if you're asymptomatic, we'll keep in touch with you. We'll reassure you. If you develop symptoms, we will assess your symptom. If it's something that you can self-isolate at home, you self-isolate at home. We'll give you the cocktail of medication. That's all those that test positive. If you do not test, if you develop severe symptoms and you need to get isolated, we will then bring you to our isolation center. It's going to be at no cost to you. I mean, we've done that for one or two that have tested positive. So be reassured that you will be taken care of if you test positive and if you become sick, mildly sick or severely sick. But please note, as Dr. Powe has said, you never know who will become very sick. We've had a young person or young people, healthcare workers that have died. So that's why it's important to take all precautions. But the more dangerous thing is that you may not be very sick or be sick and get better, but take it to a family member who becomes very sick and never recovers. You won't be able to forgive yourself if a family member dies as a result of you getting infected at work. And the thing is, you still have to continue to work. You have to continue to work and move on with life. So that's why it's important to make sure you take all the precautions and everything in this training has to be taken very seriously. Now, the other thing is for those that worry about, some people have asked us that, okay, how about for those of us that have been exposed, who don't have symptoms, can we have the cocktail of medication? The medications are basically multivitamins. And we've looked into, if you want it, we'll make it available if you have been exposed. So there's nothing to worry about. And part of the prevention, don't forget, is also this training. And as I've said, the videos will be made available to everyone, and there will be a post-test after this training. So I will have Dr. Ejima can say one or two things, and the CEO will also speak to us as well. Thank you, everyone. Dr. Ejimakin, you have the floor.
Good afternoon, all. Thank you very much, Dr. Opawoye, for a wonderful presentation. I hope the next time we invite you, you also come, even though it took close to 2 hours. We really appreciate the presentation. I'm sure everybody enjoyed it and had a good time. Thank you also very much, Dr. Babajide, for moderating. Thank you very much also for doing a fantastic job in the occupational health unit. Please note the QA team will definitely be working more closely with you over the next few days and months to ensure that we implement the COVID-19 response for staff, as well as implement the policy across all the branches of the Redditing Group. I'd like to appreciate everybody who was able to participate and all the team leads for joining. Please note there's a recording. We also have a recording, and this event is also on YouTube. So people who were not members of your team who were not able to link up this afternoon, please ensure that they still go back, listen to the recording, and take the post-test. The post-test, we will share the post-test link immediately after this event through your team leads. It's just 10 questions, very simple. The pass mark is 80%. You're allowed to retake it again. And there's also a certificate that comes along with it, a certificate of achievement. So please note, the post-test is compulsory for all healthcare workers, all right? And we have the records of everybody who will take it. And sanctions might be applied for people who do not take it. Thank you so much, everyone, and have a good evening.
Thank you, Dr. Ejimakin. CEO, sir, can we have you say one or two things to us? I'm not sure, is he still here? Is he still here? Sir?
It's possible he's attending to something else. Nobody knows.
I think he's no longer here.
There's no water now.
Okay, since he's not here, I'm not sure Mr. Matthews is here. Dr. Shibamor, can we have you say one or two final words before we call it an evening? Right. I know Dr. Shivamor complained about having a very poor network sometimes in the course of the meeting. So, okay, so in the absence of that, thank you everyone for attending. Thank you very much for sparing your weekend. It's been a long session, so we'll call it enjoy the rest of your weekend, and we'll be in touch with you. Thank you.
Thank you.
Bye, everyone.
Bye. Bye.
Bye.
Bye.
Bye.
Bye. Bye.
Bye, ma.
Bye.
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 Bye. Bye.